Prostate cancer is a really lovely but difficult space to work as a clinician and as a researcher because it moves quite quickly, right? So not that long ago, maybe within the last 10 years, we really, for patients with metastatic castrate-sensitive disease, had just an ADT backbone. But in the last 10 years, we've seen a lot of evolution in treatment. So what we mean by treatment intensification is really an ADT castrating backbone and then the addition of intensified therapy. And initially we meant docetaxel, and that was the charted data and STAMPEDE data. And since that time, we've seen a number of these androgen receptor pathway inhibitors come on board. So we have abiraterone, we have apalutamide, we have enzalutamide. And then in the last couple of years, we've seen the combination of the chemotherapy backbone with an androgen receptor inhibitor. And so today, we now mean what we call doublet therapy, which would be ADT plus one of these oral androgen pathway inhibitors, or we mean triplet therapy, which is that plus the addition of docetaxel-based chemotherapy. And either one of those approaches, I think, is the standard of care for most patients with metastatic castrate-sensitive disease. There's clearly a subset for whom this isn't appropriate, but that should be our default for the majority of patients. Anytime there's a change in practice, there's changes in habits and changes in behavior that have to correspond with that. And so I think we've seen as a community that uptake of treatment intensification in this disease space has been a little bit slower than we would have hoped. In the first couple of years, we were seeing 10 or 15% of patients who we thought would be potentially eligible receiving this therapy. Some of the newer data into 2021, 2022, we're maybe getting close to 50%, but that still means there's a large group of patients who aren't getting intensified therapy. And there's a variety of reasons why this can be. At the end of the day, everything in medicine is about patient-directed care. And so there's patient factors, there's patient's preferences, there's physician-related characteristics, there's maybe systems level barriers to care. And so we need to look across all of these. I think the last one I want to allude to first, just systems level. One of the things we see that I think is remarkable in this space is that this is a remarkably consistent observation with difficulty with treatment intensification or relatively low rates of treatment intensification across jurisdictions. So whether we look at, a VA population in the US, we look at a commercially insured subset, we look at Medicare patients, we go to Europe, we go to Canada, regardless of the healthcare setting, we're still seeing these issues, which makes me think, at least, that it's not so much about the system, it's more about, the way patients see this addition of therapy and the way physicians see this addition of therapy. Maybe set a context of what we're trying to achieve here. So we looked at patients who are newly diagnosed with metastatic castrate-sensitive disease, and we're trying to understand who's getting intensified and who's not getting intensified therapy. And so to do that, we had a population-based sample, about 4,000 men, and we're trying to look at those predictors of intensification. And at this point in time, we're looking across the spectrum of time, so any form of intensification qualified, whether that was an ARSI-based doublet, whether it was a triplet therapy, whether it was docetaxel-based doublet back in a more historical context. And we're really seeing that there are numerous drivers for our treatment intensification. The biggest, I would say, negative predictor is patient age. And so this is a fine line and a bit of a nuanced conversation because we certainly know that older men often harbor aggressive prostate cancer that warrants aggressive therapy, but they're also at higher risk of experiencing the burden and the toxicity of our added therapy. And so, when we look at practice patterns, it's certainly one of the strongest predictors of patients not receiving that treatment intensification is older age. And that's one of the things that really stands out. Comorbidities actually didn't stand out in a real dramatic way, in a way that was a bit surprising to me. But we did see stroke, a prior history of stroke as a strong predictor. And I think that's relevant, particularly when we think of certain subsets of ways we intensify. So there's certain of the androgen receptor pathway inhibitors where we're maybe worried about seizure risk in a patient who has a neurologic history. And so those factors are clearly playing into physician and patient's judgments about life expectancy and the risk-benefit trade-off of this addition of therapy. the other thing is, we're trying to capture some sense of disease characteristics, and so I think we all expect that patients with more volume of disease maybe are going to be more aggressively intensified, so those high volume, high risk patients. But I still think when we take a step back, those are our practice patterns, but the data really support that intensification, even in those low volume patients and even in the latitude low risk patients. And so we shouldn't use low volume metastatic disease as a reason not to offer life prolonging therapy. What we're trying to do here, and it's a little bit complex analytically, is to make sure we're capturing all aspects of how a physician manages their patient. So some physicians may be comfortable doing the treatment intensification themselves, and that's great, but others may not and may want to refer to someone else, and that's also good clinical care. And so the way we've tried to do this is we tried to look at it from the basis of who is the physician who's starting this patient's care. And so in this context, it's the patient receiving their ADT. And so who's the physician prescribing that ADT? And we're looking at that as a predictor, whether that physician is themselves the one who does intensification or whether they refer out and someone else does the intensification. And so we're looking and we're seeing there is some variation between specialties. And so we're seeing non-significant differences between urologists and medical oncologists, but somewhat lower rates of treatment intensification in the radiation oncology a subset. It's really hard to know exactly what that means at this point in time, and so we're gonna need a bit more research to understand those characteristics. I think there is also a lot of variation within specialties, so that's a big broad sweeping statement, but there's a lot of physician to physician heterogeneity, and the specialty probably doesn't capture the nuance. There's probably more differences within radiation oncologists than there are between the specialties. But it's really a goal to try and help us lay a framework for how we might think about future QI endeavors to try and improve treatment intensification uptake in the community more broadly. Yeah, I mean, the trouble with these kind of studies is that you trade off granular nuance, knowing all the details about what's going on for any given patient, for generalizability. You kind of get to pick one or the other. You either do a study of all the patients at your center, in which case you can look at all of their details in a really granular way, but you maybe don't know what's happening in the rest of the community, or you do the opposite. So we went for generalizability. So this is a population based, this is all comers. So there's certain nuances about, for example, the volume of disease and the distribution of metastatic disease that we don't know. We know all these patients have metastatic disease, but do they have bone-only disease, or is there some visceral disease? Those kind of nuances are beyond what we can capture here, and I think they do play into clinicians' judgments about how to treat these patients, and so certainly I think that's important to understand what we can and can't capture. To some degree, I think the reason why we did this study is we don't actually know what's driving the lack of uptake. And so, education when new data comes out is always key, but treatment intensification, the charted data are from 2015. It's not like this hasn't been around a while. And so there's certainly good work that's been done by one of my friends and colleagues, Steve Freeland, on this with some survey data. There are concerns about toxicity and the toxicity relative to efficacy trade-offs. That's certainly an education kind of component, both in terms of understanding the benefits of the treatment, but also understanding how to give it safely. I talked to some of my peers who are worried about, the toxicity management and being a prescriber of these drugs and how to take care of the patients when side effects come up. And so there's an education component there for physicians. There's an education component for patients as well. And I have to say, I think there's variation between diseases. You see the advocacy that goes on in breast cancer, and it's a little bit different in prostate. And I find, the conversations in prostate cancer, very many patients are really aggressive and want a lot of therapy, but a lot of patients are wary about the effects on their quality of life, and it's a bigger explanation maybe, and a larger counseling exercise to help them understand the trade-offs between the expected survival gains we can get from these agents and the side effects. And so I think there's a lot of work to be done kind of across the spectrum, and hopefully what this analysis is showing is it's not just one thing. It's not just old sick patients don't get therapy and everyone else is getting it. There's a lot of factors at play here, and this is there's a whole field of science and implementation science, and it's because this kind of work is complex.